Our first speaker is Dr. Chandra Ford. Dr. Ford is an associate professor in the Department of Community Health Sciences and founding director of the Center for the Study of Racism, Social Justice, and Health at the University of California, Los Angeles. I can think of no better person to kick this off. So welcome, Dr. Ford.
Good morning, and thank you for having me. I'm delighted to be with this distinguished roundtable and the committee, and thank you for your assistance in getting this going. I'm going to pull up my slides here. I have no conflicts of interest to disclose. I conduct my work on lands originally inhabited by and cared for by the Tongva people. So I say this to acknowledge that even those of us who are fighting for racial equity are complicit with and benefit from the historical and ongoing injustices visited upon the indigenous peoples of the Americas. I was asked to speak about structural racism, power dynamics, and system science approaches toward obesity solutions. My remarks focus on critical race theory's potential to inform this family of methods known as system science. These methods help uncover complex relationships between systems that together contribute to morbidity and mortality in populations. Likewise, critical race theory draws on sophisticated, conceptual, empirical, and other approaches to identify and explain otherwise imperceptible racial drivers of inequities in our society. Racism has been defined as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, that disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources. Critical race theory is a specific set of intellectual ideas, principles, and approaches originating with legal scholars of color in the late 1980s to identify, understand, and undo the relationships between race, racism, and power as they operate in the post-civil rights era. These more nuanced forms of racism remain entrenched and effective at sustaining racial inequities. The central questions that critical race theorists pose for any project are: how is racism relevant to this project? And also, how is racism relevant to the production of knowledge about the problem? Some sense of critical race scholarship can be gleaned from the work of these founding critical race theorists. Derek Bell, the father of critical race theory, asserted that to address these less perceptible forms of racism, their mechanisms must first be made explicit through racism-conscious research. Kimberly Crenshaw, on the left, coined the term intersectionality to explain that systems of oppression, for instance, racism or sexism, are interlocking, and the non-additive synergistic effects of this for people with multiple minority statuses, for instance, those who are Black and women, cannot be disentangled. And a brilliant jurisprudential analysis by Cheryl Harris revealed how the courts, having codified race relative to citizen rights and whiteness as the racial category to which the fullest citizen rights accrue, essentially treat whiteness as a form of property. Those who possess this property have, for instance, the exclusive rights of possession and the absolute right to exclude, which means that as the law has been interpreted, those possessing whiteness have no obligation to share this privilege, and those who do not possess it have no inherent rights to it. I will not elaborate on it here today, but do know that my remarks are actually rooted in the public health critical race praxis offshoot of critical race theory. Additional information on it is available from these publications. Essentially, it enables us to apply critical race theory in the health sciences. Every model, including those used in system science, is an imperfect representation of reality. So I would like to discuss just 3 recommendations to help address the constraints of this. First, systems science research should draw on the substantial evidence linking racism to health. Dynamic systems models that include appropriate measures of racism may hold particularly high potential to illuminate how structural racism contributes to obesity. Useful measures of racism at the individual, institutional, and other socioecological levels are available in these resources shown here. This research should also measure race and ethnicity as social constructs. And that's because races, quote unquote, are not absolute entities in and of themselves, but relational markers of social mechanisms acting to produce groups and hierarchies. So races inherently exist relative to one another. So to say that race is a social construct is to say that it is a vast group of people loosely bound together by historically contingent, socially significant elements of their morphology and or ancestry, and that it quote becomes in social fact what it is supposed to be in naturalist theory, a differentiating trait that orders us in hierarchical terms as members of inferior or superior races. Now, certainly few would use the language of inferior or superior races today. Nevertheless, the ways in which we use race continue to reflect that underlying orientation. Focusing on social construction, suggests the need to consider whether, for instance, to assess perceived race versus self-reported race, and how self-reported race might differ from identity. Also, how gender, ethnicity, and other factors may inform both perceived and reported identity. In the interest of time, I will only mention here that ethnicity is a social construct too, and strategies exist to capture its social constructedness. Secondly, community-based participatory research, or CBPR approaches, have long encouraged equitable partnerships between researchers and communities as an ethical and sustainable path to health equity. In a systems science environment, power sharing will become even more important to the extent this environment enables researchers to gain access to much more information about communities than communities can access themselves. Racism is embedded in some forms of big data, and big data may be used in ways that reinforce racial or ethnic marginalization, as detailed in these recent books. For instance, surveillance mechanisms disproportionately target people of color for criminal, social, and other forms of policing. Various systems may share data about individuals and communities without involving or seeking consent from these communities. Social movements that challenge these practices, such as Data for Black Lives, are emerging in order to limit surveillance of communities and democratize access to data by placing the tools of data science in the hands of those historically targeted by surveillance. Third, all knowledge is socially constructed and scientific knowledge is not accepted. Quote, data never speak for themselves. It's the questions we pose and those we fail to ask, as well as our theories, concepts, and ideas that bring a narrative and meaning to marginal distributions, correlations, regression coefficients, and statistics of all kinds, says sociologist Larry Bobo, and to the models developed in the family of methods known as system science. Quote, the systematic nature of the scientific method enhances the reliability of empirical and scientific findings in our bodies of evidence, but does not necessarily eliminate the influence of racial bias. I encourage what I call critical reflexivity to help researchers understand how we may bring subjectivity to the work we do. In this HIV testing linkage and retention and care study. This was a 5-year retrospective cohort study among Southern California adults enrolled in primary care or HIV care in 2 large regional healthcare organizations. And we linked multiple sources of data, those shown here on this slide. In order to try to understand how we might bring assumptions to the work we do, our hypotheses, though evidence-based, we believed it possible that all else being equal, it may be conceivable that upon seeing the raw data, one might be more inclined to endorse potential results that align more closely with one's a priori assumptions than otherwise. We integrated surveys of the research team at key points over the course of the study. Items with open-ended and Likert type response options assessed each person's, for instance, expected results relative to each set of analyses, a level of certainty about the predictions they were making, the nature of any disparities they expected to see, and the reasons that they were making these particular predictions or holding these expectations. As explained at the time, there were no right or wrong answers, and individual results were not disclosed to other team members. Through later debriefing, we learned that this exercise itself was an intervention. Some evidence on implicit biases, for instance, those among providers, suggests that simply by raising one's awareness of their biases and increasing the amount of time they have to respond to them, we may reduce the inadvertent effects of implicit biases. So this is anecdotal only, and it's not a test of implicit bias, but it moves in that direction. This was conducted in a statistical hypothesis testing environment. Systems science certainly has the capability of doing this more comprehensively and more rigorously. I've shared 3 ways a systems science approach to obesity solutions can draw on critical race theory, but there are still questions that I believe could guide this work further. In the interest of time, I think I'm out of time, I'm going to list them here and I'd be happy to return to them. Allow me to conclude, obesity is a complex phenomenon for which systems science approaches hold promise. They are also well suited to bring to light racism-related dimensions of obesity, morbidity, and mortality. Despite some gains, racism continues to pervade every system in society, though its greatest impacts are difficult to perceive. Critical race theory can aid systems science in identifying underlying racial drivers of obesity inequities. Thank you.